Hi, Dr. Brian Bailey here. After doing thousands of orthodontic consultations, I've decided to try to videotape some of it to be more efficient. So that's why you're watching this tape. I wanted to go through a standard list that we use during consultations to explain a lot of what goes on in orthodontics and what you need to know ahead of time. So on this form, we're just going to go right through this nice little checklist that I do. This is actually a checklist for me, but it's good for this video illustration. The first one on the list here is the braces appointment policy. And what that means is we have most of our orthodontics are on teens, and most of them want in after 3:30 in the afternoon, and we can't fit in 100 kids in a month if we're seeing them all after 3:30. So we, about 20 years ago, came up with a policy of alternating visits where you can have one late in the day, then one early in the day, one late in the day, one maybe at noon. So that one has to be basically during the day and then one late in the day. And it's worked out really well for our patients and our practice. We just ask a little flexibility and it works great. The appointments are about a half an hour long. They're once a month, and that way we can stagger them and get everybody in. So the next thing on the list is braces in my bite. And what that means is during the braces, when the teeth are moving, the bite's going to feel funny. At the end, we're shooting for the best possible bite we can get. But while a tooth is moving, it's going to go from where it's been used to a new spot, and in between it can hit strange. That sometimes can cause problems with the jaw joints, sometimes can cause a sore tooth. It's usually not an issue. I mean, it's very unusual that it is, but we want people to know that during the process things can feel really strange. It's just the key at the end is that we have it as comfortable and as functional as we possibly can. The next thing on the list is breakage. And what that means is, when we're doing traditional braces, not Invisalign or Clear Correct, we know people are going to break things, meaning that wires might break, brackets might pop off, the little donut that holds the wire to the bracket might come out. We expect it. There's no extra charge when things like that happen. We like as little as we possibly can because it's extra trips for you guys. But the key thing is that we know about it, because we've had cases where we're almost done, we're a year and a half into the braces, we're about ready to get them off, something breaks, the kid doesn't tell the parents, and the bite is so far off that there's no way, one, that we can ever take the braces off at that time, but sometimes we even have a hard time getting back to where they were. So the key thing is the child or the adolescent is not going to get in trouble for breaking things. They're going to get in trouble for not telling their parents so they can let us know. So there has to be a good open dialogue between the parent and the child that they're not going to get in trouble. The next thing on the list is compliance and non-compliance. There are certain parts of orthodontics where it's completely out of our control as the clinician, and things like wearing rubber bands, the do's and don'ts list that we provide in their education, the things they can eat, the things they can't, etc. It's just huge. I mean, there are cases where we absolutely cannot treat the case without good rubber band wear, or if something's broken constantly by breaking the rules, that compliance is very important in an orthodontic case. Another part on this list is any hidden fees. Basically, everything's included in the fee that we provide for you. It doesn't matter if it takes a year or 10 years, if nothing's broke or everything's broke. What is extra is at the end we provide multiple retainers. That provides for things being lost, broken, etc., and not worrying about the teeth going crooked because you always have a backup. Well, if all of the backups are broken or lost, then there's extra expense. But otherwise, there are no hidden costs. Everything's included on the price that you've been quoted. There are additional things that quite often need to be done, such as a frenectomy, or exposing a canine, bonding, etc., that might be in addition to the orthodontics. But the orthodontic case, all the visits are included, breakages included, etc. Interceptive or early phase treatment, what this means is when we do treatment before all the permanent teeth are in. When there's what we call a mixed dentition, which means baby teeth and permanent teeth. We only do that in cases of what we call an underbite, which is like this, a open bite, which is where if the back teeth are hitting like this but the front teeth don't hit, we have to intercede early there. If there's severe crowding that needs extractions, etc., anything that is done in what we call a first phase of orthodontics quite often needs a full second phase later. So we avoid it. We do as little two-phase orthodontics as we can. There are just certain cases where you have to in order to be able to correct the case. The next thing on the list is IPR. What that stands for is interproximal reduction. And what that means is if, particularly on adults, if these lower teeth are very crowded and we need to line them up, there's only two ways we can line them up. One is we can make the arc of teeth bigger so that they fit in, or we can make the teeth a little bit smaller. Most adults, if we try to make this arc bigger, we are going to cause the gums right here to recede. So in a lot of adult cases and some kids cases, we do interproximal reduction. So let me explain quick here on this piece of paper, if the camera can see it, what IPR is. If this is a lower front tooth, and this is the enamel on the outside, and then this is the nerve coming up the middle. This enamel thickness is usually 1.5 millimeters, and what we can do is we can take it down to 1 millimeter without, you see how this is a little bit thinner here than this, without causing any detriment to the tooth. This doesn't cause sensitivity, it doesn't hurt to have it done. Sometimes it's a little cold sensitive while we're doing it, and I've done this literally 1,000 times. In fact, it's been done to my lower front teeth. Back in the 50s and 60s, they used to call it keystoning. They would do it just to get this flat contact point of this tooth to the next one so that the teeth would be more stable and not want to go crooked again. So IPR is essential on some teeth, and the most we ever take off is 0.5 millimeter between two teeth. So I wanted to give you an example of what that amount is. This is the most we ever take off. Here we have tooth colored porcelain brackets on the teeth, and we didn't have quite enough room on an adult, and we did IPR, interproximal reduction, in that spot, and that's the most that we ever take off. So it doesn't cause any detriment to the teeth, but we can do a lot of positive things by a little bit of IPR. Now the other thing to know about IPR is we try to do it over as many teeth as we possibly can, and the reason being is if you do too much in one spot, there can be problems. But if you take a teeny bit off of many teeth, you can gain a good 3 millimeters down on the lower front teeth and have room to line them up without causing any detriment to the teeth. So that's the concept of IPR. It's been a beautiful thing in the practice the last 20 years to help a lot of people. Oral hygiene, that is probably the most important part of all of orthodontics. If you don't keep clean around the brackets, keep the plaque off from around the brackets, and the teeth start to decay around the brackets, then we're all in trouble. So most cases, if an adolescent, for example, is getting E's on their appointments when we grade them when they come in, then we can't get an A on the case. I mean, we can get an A on the case every single time if somebody is getting A's or B's on their brushing. So we grade them every time they come in. If they get an A, they get a gift card to Midland Cinemas. And if they don't get an A, we show them how to get an A. If a child is getting E's more than once, then we beg the parents for help. We usually send a letter and then ask for help because we just cannot get the case where we want. Now these are some examples of what happens with poor oral hygiene. This is where a bracket was, and you can see the tooth is all chalky here, chalky here. This is actual decay. And this person obviously left a lot of plaque between the gum line and the bracket, and we will educate a lot on how to keep that clean. And then here's another example. These neither one of these are my patients, but this one was from a local orthodontist, and there was actual decay in here that I was starting to drill out, and I said, I need to get a picture of this. But the problem is, your whole life you will be dealing with a flat finished tooth instead of glossy tooth, so it's much harder to clean and keep the bacteria off. So literally when you're 40 or 50 you can still be getting cavities in these chalky areas because they're so much harder to take care of over time. So the next thing on our list is pain. Pain in orthodontics really varies tremendously. I always use the example of myself and my brother. He was 4 years older than I was. He had pain the whole 2 years. I never even had to take an aspirin. So everybody's different. There is a significant difference nowadays because we use brackets rather than we only use a few bands. And our wires are primarily nickel titanium, which are really a slow force that isn't abrupt and doesn't cause anywhere near as much pain as stainless steel. We still have to use some stainless steel in spots, but we always start a case with a real light nickel titanium wire so that the people are getting used to the brackets on their lips, their tongue, etc., and not having a lot of pain in the teeth. And then the next appointment we go to a little bit stiffer nickel titanium, and that can cause some comfort in the teeth, but now their lips and tongue, etc., are used to the brackets. So that's how we avoid a lot of the pain. And then with liners, if you're doing a Invisalign or Clear Correct, we'll coach you on how to put a new aligner in right after dinner with some Tylenol or Advil, wear them overnight, and by the next morning the majority of your discomfort is gone. And as long as you keep them in and don't keep taking them out, then you won't have pain. So there are a few things that we do specifically to try to keep it more comfortable. We do ask people to try to use Tylenol rather than Advil or ibuprofen if they can, just because the anti-inflammatory does help the pain that comes with ibuprofen, but also we want the inflammatory response for the tooth to move. That's the mechanism in which it works. So if we can get by with Tylenol, it does cause a little better tooth moving. The next step is very important, and that is what I call the 3 R's. This is extremely important in all orthodontics. One of the 3 R's is recession. And this is a photograph of a case where this gum is receded down far enough that it is going to need a gum graft put over it. Now, most cases of recession, especially in adolescents, we can tell ahead of time that spot is going to be an issue. But what recession occurs from is that teeth quite often have to be moved out into a bigger arc in order to become straight. Well, sometimes people don't have enough bone and gum here. It basically doesn't ever happen on upper front teeth on kids, but lower front teeth, if there isn't enough bone and gum right here to make a bigger arc, then that spot is probably going to need a gum graft afterwards. Now, in adults, we have to be extremely careful not to move the teeth out too far and too big of an arc, because the bone and gum will not grow as the root moves, because they're non-growing individuals. So we have to quite often do the IPR that we mentioned earlier and make the teeth smaller in order to prevent recession from occurring. So recession is one pitfall, if you would, of orthodontics, and we have to be very judicious to try to keep as little of that as occurring as possible. There are some cases where we know it's going to happen, and we'll try to let you know ahead of time. The other of the 3 R's that's very important to know about is resorption. And what resorption is if we're trying to move these 2 front teeth, this is an x-ray, what's supposed to happen is the bone is supposed to change and allow the root to move. Sometimes the cells in the body, instead of changing the bone, change the root, and the root dissolves away. This cannot be regrown. So what happens is you get done with an orthodontic case. Again, this is an adult case from a local orthodontist, and the roots are much shorter. They should be about this long, and it's because of the body setting up the wrong process in that spot. Now, majority of the time, this is not an issue. It doesn't cause loose teeth. It doesn't cause dead teeth. It doesn't cause sore teeth. It just shows up on an x-ray. There are some real extreme cases where through the decades this continues to go on, and somebody's 40 years old and they have a little teeny root on an x-ray. But for the most part, it's just what we call that the root tips are resorbed or slightly dissolved away. It doesn't happen very often in adolescence. It happens quite often in adult orthodontics. The most important R of the 3 R's is relapse and retention. And what I mean by that is these teeth, if they're crowded, when we start a case, there is a study done by Dr. Little at the University of Washington that is about 55 years old now, that has rooms and rooms of models to show that 80% of the time these lower front teeth are going to grow crooked again sometime in your lifetime. So you only have a 20% chance of these staying straight if they were crooked when we started. So how we get around that is, majority of our cases, we bond in what we call a bonded retainer. So this is the tongue side of the lower teeth, and this is our most common retainer that we put in. It's called a Splintex retainer, and what we do is we take a little bit of bonding and we tack that wire to each tooth, and it keeps them straight. It's nice in that you don't have to worry about wearing a retainer or losing a retainer. The only hassle is it's a lot harder to clean around than natural teeth. You can't floss in between these teeth. The wire tends to be, and the bonding tends to be kind of a seed bed for tartar and plaque. So if you're good with a water pick, which would take literally 20-30 seconds a day to clean around this, then there are no issues. This is a beautiful thing if you're a water picker. People ask, how long do these stay in? They stay in as long as the hygienist says things are healthy. We have people that have had them in for 20, 30 years, and they're still in there, they're fine, and they keep the teeth straight. This is one that if the teeth weren't really crooked, we use a lot of times because it's so much more hygienic. This one you can floss, but if you have individual teeth that were very misaligned, you can't use this one. So when does it come out? It's when the hygienist says, hey, things aren't healthy. Usually they're not bothersome to the patient. They don't even know they're there. The other thing is, if they do break, etc., we warranty them. We'll patch them up, fix them up, put new ones in, whatever we have to do to keep these things going so that you keep straight lower front teeth. So this is called a bonded retainer, and we rarely put it on the upper, which is that one, but we routinely will have it on the tongue side of the lower teeth to try to keep them straight. Now, the time of treatment is next on the list. It's going to really vary from case to case. We have some simple adult cases where we're just straightening lower front teeth that are 3 to 6 months. We have some two-phase orthodontics that'll be a year once and 2 years later, so literally 3 years. Our most common case would be what I call a year, and my year in moving teeth is 10 to 18 months, because even that varies a lot. And then when I say an 18-month case, it's really 12 to 24 months. So the time of treatment varies tremendously, and we'll have to go over it on your individual case. We, in this consultation, will be providing you with an estimate of the cost of the treatment, of what your insurance will pay for. As far as payment plans go, we have so many different ways that we have people pay for it. We're very flexible on how it gets paid for. I mean, some people will pay it all up front, have a 10% discount. Some people will put half into 1 year's flexible spending account at work and half for the next year and pay for it that way. Some people pay for it all through their health spending account. Our most common payment plan, if you have insurance coverage, is $1,500 down, $150 a month. And our most common, if you don't have insurance coverage to pay for part of it, is $2,000 down, $200 a month. But that is just a common one. We have many, many, many different plans. And as long as you and our financial coordinator have a plan mapped out ahead of time and agreed to, we're really flexible on how it gets paid for. We do have an informed consent form that goes over all that I'm going over, plus a ton more that does need to be signed. Usually what we do is at your education visit, either the parents need to come in and read this, ask questions to the assistant and sign it, or if you want to take it with you, read it and bring it back, you can. But before we start treatment, we do need this informed consent. It goes over resorption, recession, etc., and other things on this informed consent form. Wisdom teeth are something that we cover in orthodontic consultations routinely, and the reason being is that 50% of lower impacted wisdom teeth, meaning ones that are stuck, are going to cause big issues in your 5th or 6th decade of life. Therefore, it's much better to get the wisdom teeth out before they have big long roots that are sunk into the bone, wrapped around the nerve that goes to your lip that can cause a permanently numb lip. So at the consultation, we look at the wisdom teeth and we predict how many are there, and how developed are the roots, how developed is the bone over them, because we don't want to take them out too early because it causes more pain and suffering for the patient, for the surgeon to have to remove more bone. So the best way to handle the wisdom teeth is when the orthodontics is done, we retake the panoramic x-ray and we can see exactly how developed the roots are, how much bone is over the wisdom teeth, so we can estimate when the best time for that individual would be to have the wisdom teeth out. The surgeons love me because I'm able to look at the films and say, I think at age 17 there's going to be very little bone over them and the roots aren't going to be formed, and it's much easier on the surgeon and the patient. And again, the reason why we take them out young is so you don't worry about the roots around the nerves, and we don't worry about cysts, infection, tumors, etc. that majority of the time will happen later on in lifetime. The last thing to cover is sealants, and that is, in the past, it's extremely common to have your molars sealed as a 6 to 8 year old and a 12 to 14 year old on your molars. In the past, years ago, we used to seal all of the premolars, which are the teeth just in front of the molars, and it's fun to see kids come back from college really straight teeth, but also have all their premolars sealed, so you can't get cavities. Well, it reduces the decay rate by 50%, according to the American Dental Association. But in our practice, it's really rare to ever fill a tooth that's been sealed. Do we? Yeah, it happens, but the majority of molars that are sealed and do not end up with fillings. So what we've done is, when we're going to be in here bonding, brackets on anyway, we have reduced the costs considerably on sealing the premolars. So If anybody wants to have the premolar sealed, you got to let us know ahead of time so we can schedule that in time in our appointments. But basically at half price, we will have all 8 of the premolars sealed, and that will hopefully keep all the back teeth from having decay and biting surfaces through a lifetime. So yeah, thanks for your time and listening to all this information. It saves me from having to go over a lot of things. Please though, during the consultation or during the education visit, if you have questions on any of this, let us know and we'll try to get an answer. Thank you very much.